Welcome back to the Deep Dive. Today we're focusing on spontaneous bacterial peritonitis, or SBP. Our mission here is really to nail down the key info you need for revision. Quick recall stuff, we'll cover it all, definition to complications.
Sounds good. Let's get into it.
Okay, so first off, what exactly is SBP?
Right. So SBP, basically, it's an infection of the peritoneal fluid, the ascites, that builds up. But critically, there's no obvious source inside the abdomen, like a burst appendix or anything.
Ah, okay. No surgical source.
Exactly. And it almost always happens in patients who've got ascites, specifically because of liver cirrhosis.
Got it. Infection of the belly fluid, no clear hole or tear, and usually linked to liver cirrhosis causing that fluid.
Yeah.
So how does it actually happen? What's the mechanism?
Well, the main idea is bacterial translocation comes from the gut.
From the gut.
Yeah. See, in advanced liver disease, the gut wall can become a bit leaky, and the body's immune defenses aren't working as well as they should. So bacteria that normally just live in the gut can kind of sneak across into the acidic fluid, and once they're there, they can multiply and, well, cause the infection.
Peritonitis.
Right, translocation from a leaky gut plus weaker defenses. Makes sense. So who's most likely to get this? We have a mnemonic in the notes, LLAGP. Can you break that down?
Sure. LALAGP is pretty useful. The first L is for liver disease, specifically advanced cirrhosis.
Right.
And A for ascites itself. You need the fluid there.
Right.
The second L is for low protein in that acidic fluid, generally less than about 15 grams per liter. Makes it easier for bacteria to grow.
Lower defenses in the fluid itself.
Exactly. Then G is for gastrointestinal bleeding. A bleed can upset the gut balance.
Ah.
And finally, P is for a previous episode of SBP. If you've had it once, you're unfortunately at higher risk of getting it again.
LLAGP, liver, ascites, low protein, gut bleed, previous SBP.
Got it. So if we think about the sequence, bacterial overgrowth first.
Often, yes. You get more bacteria than usual in the gut. Then the gut barrier function is impaired, it's leaky.
Combine that with a compromised immune response overall because of the liver disease.
And the bacteria get across and cause trouble.
Precisely.
Yeah.
They translocate and cause peritonitis.
No, someone comes in maybe with belly pain, fever. What else could it be? What are the main differentials?
Yeah, really important to differentiate. Top of the list is secondary peritonitis. That's where there is a clear source, a perforation, an abscess, something needing potentially surgery.
Okay, so you need to rule that out.
Definitely. And you also think about other reasons for infected ascites, maybe from tuberculosis or other general intra-abdominal infections that might just present a bit unusually.
Right. How common is SBP? What's the incidence like, say, in the UK?
It's actually quite common in the specific group. Estimates vary, but somewhere in the range of 10 to 30% of patients who have both cirrhosis and ascites will develop SBP at some point.
Wow, up to nearly a third. Significant.
It is a serious complication.
So what signs and symptoms should make you really suspect it? We've got another mnemonic here, F at was. Ah, yes, F at was. It's a good reminder. F is for fever. Common, but not always present.
Okay.
A is for abdominal pain or tenderness, often diffuse. T is for that tenderness when you actually examine the abdomen.
Right.
Worsening ascites is the WA bit. Sometimes it's subtle, just feeling more bloated or their girth increasing.
So the fluid gets worse.
Can do. S is for signs of systemic infection, feeling generally unwell, maybe a high heart rate, confusion, which links to the final A.
Which is?
Altered mental status.
Yeah.
That could be anything from mild confusion or drowsiness, right up to hepatic encephalopathy worsening.
F that was. Fever, abdominal pain, tenderness, worsening ascites, systemic signs, altered mental status. Good one. But you mentioned not everyone shows all these.
That's right. Especially older patients or those already quite unwell, the presentation can be subtle, maybe just worsening confusion or kidney function.
So high index of suspicion needed. How do you confirm it then? What are the key tests?
The absolute key investigation is analyzing the acidic fluid. You need to get a sample via paracentesis, tapping the fluid.
An acidic tap.
Exactly. Send that fluid for a cell count, specifically looking for the neutrophil count. An elevated count, typically over 250 cells per cubic millimeter, is diagnostic.
Okay, neutrophils are key.
Yes. And you also send it for culture to try and grow the bacteria. And gram stain, though the stain isn't always positive. Blood tests help assess severity, maybe look for sepsis markers. Imaging, like an ultrasound or CT, might be done mainly to rule out secondary causes.
Right, rule out the surgical stuff. So you've diagnosed SBP. What's the treatment?
It's antibiotics, promptly. You need to target the likely bacteria, which are often gut organisms like E. coli or Klebsiella.
And what antibiotics typically?
Local guidelines vary, of course, but a broad-spectrum intravenous antibiotic like cefotaxime, a third-generation cephalosporin, is a very common and usually effective first choice while waiting for culture results.
Intravenous cefotaxime. Okay, what about stopping it happening again, or in high-risk people? Prophylaxis.
Yes, antibiotic prophylaxis is definitely indicated for some. Anyone who's already had an episode of SBP should usually be on long-term prophylaxis.
Makes sense.
Also, patients who haven't had it yet but are high risk. That generally means those with low acidic fluid protein under 15 grams per liter and either advanced liver disease, like a child Pew score of 9 or more, or they have hepatrenal syndrome.
So low protein plus severe liver disease or kidney problems.
Exactly. NICE guidelines suggest considering oral antibiotics like ciprofloxacin or norfloxacin for these patients, often until the ascites resolves or long-term. Also worth noting, SBP in the context of alcoholic liver disease sometimes indicates a poorer outlook.
That's really crucial detail for management. And thinking longer term, what's the prognosis like? What are the potential complications?
Well, getting those antibiotics in quickly really does improve the prognosis. It can be life-threatening if missed or delayed.
Right.
But even with treatment, complications can still occur. Sepsis is a big risk. Worsening liver failure, developing hepatrenal syndrome is a major concern.
Kidney failure triggered by the liver problem.
Yes. And as we mentioned, recurrence is common. Even after successful treatment, the underlying issues are still there, so SBP can definitely come back.
Okay, let's quickly pull that together. SBP, infection in cirrhotic ascites, no surgical cause. Bacteria from the gut are the culprits. Risks, remember, LA-GP, signs, think FAT was. Diagnosis, acidic fluid analysis, looking for neutrophils. Treatment, prompt IV antibiotics like cefotaxime. And prophylaxis for high-risk groups.
That's a great summary. Early recognition and treatment are absolutely vital for these patients.
Definitely. It really highlights the importance of acting fast. Okay, that wraps up our deep dive on SBP for revision.
Hope that was helpful.
Yeah, really useful. And remember, for more practice questions and revision resources, you can check out PassTheMSCA.com and also FreeMSCO.com.
Good resources.
And just a final thought to leave you with. Given that strong link back to the gut bacteria, how might things like manipulating the gut microbiome become part of preventing or treating SBP in the future? Something to think about. Thanks for joining us.